The following procedures describe how to prepare the LifePulse for startup on a patient. First, secure the caps on the LifePort adapter. Second, replace the standard endotracheal tube adapter with the LifePort adapter once a successful test sequence has been completed and while the LifePulse is still in the standby mode. Remember to use the same or larger adapter for the endotracheal tube. The adapters come in sizes 2.5 and 3.5. Therefore, if you have a 3.0 endotracheal tube, you would use the 3.5 adapter. Third, reattach the patient to the conventional ventilator or oscillator. Fourth, once the patient has been stabilized on the conventional ventilator or the oscillator, make the LifePort adapter connections to the patient box and the LifePulse circuit while the LifePulse is in the standby mode. Connect the pressure monitoring tube of the LifePort adapter to the patient box and connect the LifePulse circuit to the jet port on the side of the LifePort adapter. Once the pressure monitoring tube of the LifePort adapter has been connected to the patient box, the LifePulse, in its standby mode, will begin to monitor the pressures being delivered by the conventional ventilator or other high-frequency ventilator, and it will update them in the monitor section every 10 seconds. While the ventilator is in the standby mode, the update is a 10-second update. So it will take about a minute, minute and a half for the monitor to equilibrate and display an accurate PIP, PEEP, and mean area pressure being delivered by the patient's current ventilator. The important thing to remember is that the LifePulse, while in the standby mode, serves as a ventilator monitor. It's monitoring whatever ventilator the patient happens to be on as you're preparing the LifePulse. In the standby mode, the LifePulse monitors and displays the airway pressures as if they are measured at the distal tip of the ET tube. The LifePulse approximates distal tip values. So the numbers you see displayed in the LifePulse's monitoring section will be approximations of distal tip values. These pressures might be slightly different from the pressures displayed on the patient's current ventilator. That's okay. Just remember that the information is coming from two different places. Remember that the conventional ventilator displays pressures measured proximally, while the LifePulse displays approximations of distal tip pressures. We recommend that the startup decisions be based on the pressures displayed in the LifePulse monitor section. The PIP setting chosen for initiation of high-frequency ventilation will really depend on the PIP currently being monitored by the LifePulse in its standby mode. The other initial high-frequency settings are usually left at the default values, which are a rate of 420 breaths per minute and an on-time or inspiratory time of 0.02 seconds. The lower jet rates may be used at startup for patients prone to gas trapping. With gas trapping, you need more expiratory or exhalation time, and you get that by operating at a lower rate. For larger patients or patients prone to gas trapping, the rate may need to be lowered as much as 60, 120 breaths at a time. In fact, you may be able to go all the way down to the low level or the low limit on the rate, which is 240 breaths per minute. And all this, again, is to avoid gas trapping and inadvertent PEEP on larger patients or patients prone to gas trapping. Generally, the more pulmonary air leaks are a concern, the lower you're going to set the background rate, PIP, and I time on the conventional ventilator. PEEP is a much better way to control oxygenation in patients with air leak. PEEP is the most static, stable, and safest pressure we apply to babies. And the case is the same when on high-frequency ventilation. PEEP is preferred for oxygenation and airway and alveolar stabilization. The goal in these patients, air leak patients, is to operate in the conventional ventilator CPAP mode if possible. The more atelectasis is a concern, the higher the background rate, PEEP, and I time can be set. Once optimal PEEP is reached, these settings should be set as low as possible to maintain adequate oxygenation and ventilation. So your goal is really to get every patient down to CPAP if you can. Some patients may require an occasional background IMV breath during the recruitment phase, but once you stabilize with PEEP, the goal again is to get the background rate as low as possible, and to CPAP is really preferred. There are 6 basic steps for beginning jet ventilation. First, select the starting HFV PIP value. Second, press the enter button to start the life pulse. Remember, do not press enter without having the circuit attached to the patient. Third, if necessary, lower PIP on the conventional ventilator to prevent interruption of high-frequency pulses. Anytime the life pulse senses a pressure higher than it is allowed to accept, which is determined by the set PIP value, the jet will try to protect the patient by not contributing to what it perceives as a high-pressure condition. When the conventional breath goes away, the life pulse will begin operating again. So you will hear these intermittent pauses in ventilation if the conventional PIP is higher than the life pulse PIP. Fourth, lower the conventional ventilator to CPAP up to about 3 breaths per minute, making sure to maintain your pre-high-frequency jet ventilation mean airway pressure. If necessary, provide 3, maybe up to 5 breaths for non-compliant lungs until your optimal PEEP has been reached. So the sigh breaths serve to open the alveoli. The PEEP serves to keep the alveoli open. Fifth, adjust the PEEP or the CPAP setting as indicated to optimize mean airway pressure and to maintain adequate oxygenation at the lowest possible FiO2. Six, after settings have stabilized, if a mean airway pressure alarm occurs, press reset to allow the life pulse to recalculate correct alarm limits around the new settings. Do not press reset if there is a loss of PIP alarm displayed in the alarm section of the life pulse. And that's really all there is to starting the life pulse on a patient. At this point, just do the things you normally do when you start a ventilator on a patient. Observe the chest rise, examine the patient's color, look at the oximeter, possibly get a blood gas. All the things you would normally do when starting a patient on a ventilator can now be done with the life pulse.